and I'll be talking on what we do with NGS in the clinic in terms of diagnosis and management of patients with genetic disorders, or more specifically monogenic disorders. So my talk will be covering just a few slides on the basic fundamentals, which I am sure have already been covered in the previous talks. I'll be illustrating some basic principles of clinical applications through illustrative examples, and also discussing a few cases where complex issues regarding testing arise. So just a brief overview, I'm sure everyone knows this. So I'll be focusing mainly on exome sequencing because that's the area where we the modality that we use most often in the clinic. So for that, we need a capture kit which targets our area of interest, and depending on that, we get the how many genes, etc., and panels and the downstream bioinformatic analysis. So, if we have such a family with hereditary breast ovarian cancer, our question is what testing should be ordered. We all know that it is a genetically heterogeneous condition with many genes involved, and most of the genes are large, having like a pretty large number of exons. So it's either an option. So in the previous era, previous NGS, pre-NGS era, Sanger was the only option of sequencing all these exons. So now when we have this option of massively parallel sequencing and high throughput sequencing through NGS, NGS is the more cost-effective option now and is the preferred test. Now, what about the testing modalities? By testing modalities, what I mean is we are all very familiar with all these terms: whole genome, whole exome, focused exome, clinical exome, Mendelium, etc. So these are various terms which are basically industry coined terms, especially in case of exomes, because exomes, as the name suggests, is the coding region of the genome. So it should include all the exons of all the 20,000 something genes in the body. Panel, we mean a targeted group of genes according to our area of interest or the phenotype that we are targeting. Then another strategy is whom to test. Do we test only the patient? Do we test the family members whom the parents, the affected sibling, unaffected sibling, etc. So there are many strategies, and based on this, the yield differs. And based on what you are looking for, we have different strategies. Like if we do only a soma exome or a singleton exome, that is the proban only. And in these cases, the diagnostic yield is obviously decreased because we don't have the added advantage of segregation. Then we have trial exomes where we do basically the parents with the affected child or the proband. Then we have different combinations where we can group two affected individuals in the same family or different families, even when we know that this is the same disorder. Then we can group 4 or 5 different individuals. So based on this, it decreases. Then there's another way of testing where the proband or the affected individual is no longer alive, or sometimes when couples are coming to us for pre-conceptual counseling, they want to have the carrier status of monogenic disorder. So that's the carrier testing. Then once we have the sequencing, how do we prioritize the variants? Again, a repetition, I'm sure. So depending on what the variant is, where it is located, is it an exonic variant? Is it a truncating variant? What are the scores? What is the population frequency? Has it been reported previously in various databases? What is the mode of inheritance? What is the phenotype, etc.? We finally have a list of one or a few variants which we think that might be the causative variant for that particular condition. So that is the whole process of variant prioritization. Yield, again, various studies over the last a decade or so have shown that the yield differs, and the range is from 25 to 50%, again in consanguineous population, and where the phenotype is very specific, like in terms of eye disorders, etc., it is higher as compared to non-specific phenotype like developmental delay or intellectual disability. So here, important thing is, in spite of the NGS being in the clinic for over a decade, we still have more than half of the cases which remain undiagnosed. So this is now one area of focus where people are trying to do more in terms of diagnosis using other NGS modalities and metabolomics, RNA-seq, etc. So when to order an NGS-based test in the clinic, the list is very long, but just a few fundamental aspects. When you have a disease which has genetic heterogeneity, that means the disease is caused by more than one gene. So we have osteogenesis imperfecta, which is caused by more than 20 different genes. Then if you have a phenotype like intellectual disability, where it can be caused by more than 500, 600 different genes, then NGS or an exome sequencing is the way to go. Or even if you have a very specific phenotype like hereditary breast ovarian cancer, but you know that the gene is so large that doing a Sanger sequencing for each and every exon and fragment is not cost effective. So in terms of selecting the patient or the individual whom should be tested, then there is the dictum in any genetic testing that the patient who has the phenotype, unambiguous phenotype. So even in this family, if we have this 25-year-old female coming to you for testing, looking at the pedigree, we would ask them to bring this or to get this individual who is affected tested first and then go for the testing. So question is, can we test her directly? Yes, of course we can test her, but there are certain limitations, and for more appropriate interpretation of the test results and genetic counseling, it is preferred to always test the individual with the disease first. Then which test? That depends on the diagnosis, the clinical indication, what are the genes involved, what are the type of mutations that we are targeting? Is it a single point mutation or is it large deletions and duplications? Then of course, availability and cost. So when not to order an NGS-based test is now for majority of the clinical conditions, everyone is ordering an NGS-based test. So we should remember at this point of time, what should not be the conditions where NGS is not the first preferred modality of testing. So when we are suspecting a chromosomal disorder, different chromosomal disorders like enucleosis, for example, if a Down syndrome, we will order an NGS-based test. Microdeletion duplication syndromes, 22q deletion, etc. Again, we don't use, we would prefer a microarray here. Then structural variations, balance translocations, karyotype is the gold standard. So NGS is not right now validated for detection. So even if it can detect, we need an alternative method for validation. So this is not the first line modality of testing. If we are suspecting a triplet repeat disorder like Huntington disease or a spinocerebellar ataxia, then also we don't prefer NGS as a first line. In conditions where only a Sanger-based testing can be done, so it saves you money, time, and the load of interpreting various BUS and secondary findings. For example, in thalassemia, you don't do an NGS, you just go for Sanger sequencing of the 3 exons. So with this, we come to the next case here. So most of the cases, my cases will be neurodevelopmental disorders because that's my area of interest. So this is a family who came to us with this child who had severe developmental delay with refractory seizures and severe microcephaly. There was a history of similarly affected sibling who died previously, and the mother was pregnant. So basically for this pregnancy, they wanted prenatal diagnosis and hence came to us. So imaging showed some kind of pontocerebellar hypoplasia, but we are not very sure. It was like a non-specific diagnosis for us. So we decided to go for an exome sequencing, and this was the result where we got a homozygous termination truncating mutation in this MINPP1 gene, which when we looked up in women at that time, that was in 2021, it was associated with follicular thyroid carcinoma as a somatic mutation. But when we looked up the literature, this is the IGB picture of the indel here, when we looked up the literature, however, this gene was associated with pontocerebellar hypoplasia. So when we reversed phenotype our case and reviewed the MRI, there was a specific finding of basal ganglia hyperplasia, which clinched the diagnosis for us, and hence this was classified as a causative variant, a pathogenic causative variant, and a prenatal diagnosis was provided to the family. Then this was the second case which I wanted to demonstrate the use of exome in cases where we have the diagnosis clinically. However, it is a very genetically heterogeneous condition, and therefore we cannot, we prefer to do an exome sequencing. So this is again, this child came to us at 1 year, 2 months. That time NGS was not there. This was somewhere in 2010. But they came again when she was 11 years old, and by that time we have NGS as a diagnostic modality. So diagnosis clinically was primary microcephaly from the clinical picture and the MRI images. However, primary microcephaly is a very heterogeneous condition, and more than 28, in fact now almost 30 genes are known to cause primary microcephaly. Hence, exome sequencing was done, which showed this splice site variant homozygous in the NCAP-D2 gene, thereby confirming a diagnosis of type 21 primary microcephaly. This was confirmed by Sanger sequencing in the proband and the parents. So again, we have clinical diagnosis, but because of genetic heterogeneity, we prefer exome sequencing for molecular diagnosis. Then there might be conditions where we only have one positive gene. For example, in this gentleman who had cardiac abnormalities and had a diagnosis of Marfan syndrome. So Marfan syndrome is a clinical diagnosis based on certain clinical criteria. We don't need to do pathogen or molecular diagnosis as such. However, in this case, they wanted to know and were interested in doing a prenatal diagnosis. Hence, the molecular testing was ordered. But Marfan syndrome is caused by only one gene, that is the prevalent one gene, FBN1. It has 65 exons. So again, a large number of exons. So therefore, we did an exome sequencing. So exome sequencing may be done, or you can design a custom-based NGS panel which contains the FBN1 gene. So whatever your panel is, you have to have the target gene, and that's what we did. We had an exome. We did not have a panel which had FBN1, so we went for the focused exome. And the exome done in the commercial lab did not identify any variation in the FBN1 gene. But we were very sure that we always get the raw data and reanalyze the sequencing data whenever we have a report which is not concordant with our phenotype or clinical diagnosis. So that's what we did in this case. And on reanalysis, we found a heterozygous splice region variant, not in the canonical splice site, but a +9 variant here. And this variant is already been reported in literature previously with a functional assay being done, which showed that it causes a donor gain and therefore a premature truncation. So this was classified as likely pathogenic. So we see here that this is the exon intron site, and this is the +9 variant. So why was this missed? Because many labs in the annotation pipeline do not annotate it beyond the canonical spliceless site. But as we are a research lab, we always make it a point to look for and extend it. And so now we are looking at ±15 beyond the exon intron boundaries. Then we have some complex cases here. So this was a family who came to us with 2 affected children with severe developmental delay. This boy had cleft palate and had an alkaline phosphatase which was very high, and he had some stereotypical hand movements which clinched the diagnosis of hyperphosphatasia with intellectual disability. His sister also had severe developmental delay, and we were sure this is a consanguineous family, so we were sure that they had the same disease. So we decided to do exome sequencing of this particular boy. It had 6 genes, and this was the homozygous variant identified in one of the hyperphosphatasia with the intellectual disability syndrome. And we wanted to prove that the sister also had the same variant. So we did a targeted Sanger of the variant. The parents were heterozygous for the same variant. This was the proband with homozygous variation G2A. but the sister did not have the variation. This was a wild type G here. So we were puzzled. So we thought this might be a sample mismatch. So we again called the patient, we took a fresh sample and repeated the sequencing, got the same result. Then we reversed phenotype it and we saw that there were subtle differences between the two affected siblings. So we concluded that she might have a different disorder. So decided to do exome sequencing of the sister, and the sister had this homozygous frame shift variant in another gene which causes mucolipidosis type 4. So we have two different diseases in the same family. Then we are very, as geneticists, we are very, we like to give recurrence risk, etc. And this is what we calculated for this family. So really, we do get many cases where we have similarly looking phenotype. However, there are occurrence of multiple disorders, rare disorders in the same family. Then another case here with hypogonadotropic hypogonadism. We got a VS positive event in this gene. So we were very happy. Additional findings when we analyzed, we got a truncating non-pathogenic variant in the BRCA2 gene, which causes hereditary breast ovarian cancer. So this is a secondary finding. So secondary findings, I'm sure many of you know. Secondary findings are findings which are unrelated to the primary indication for which the testing was done, but these are medical value for patient management. So the ACMG have come up over the years with various list of genes for which you need to report a pathogenic or likely pathogenic variant in the lab. These are just guidelines. So many of the labs in the West follow this. In India, it is yet to catch up, but we sure will be there in the next coming few in the future, near future. So they have recently released this list, and in July last year, they have come with a list of 79 actionable genes, in which if you get any pathogenic or likely pathogenic variant, you need to return the results to the patient. So these are basically more or less related to cancer mostly, and some of them are cardiovascular phenotypes and some metabolic disorders. Then we have this last case of osteogenesis imperfecta. So clear-cut diagnosis, nothing. So we thought we will get it, but in the whole exome sequencing, we did not find any relevant variation. And as a protocol, we checked for coverage of all OI genes. Everything was normal. We did the CNV analysis from the whole exome sequencing data with nothing, no deletions, no duplications, which were relevant. So what could be the possible results of such an uninformative or negative exome sequencing? So they can be because of technical limitations or issues or interpretation issues. So technically, we all know coverage issues. Full exome does not mean that it covers whole of the exome. There may be areas of less coverage or no coverage. So the causative variant may lie outside this sequenced regions. There might be structural variations, large deletions, which are beyond the scope of detection from exome. Again, various calling issues, etc. And interpretation issues are now the bottleneck. This might be because of phenotyping issues, because of novel genes, because of interpretation of evidence of uncertain significance, etc. So one major cause is non-coding region variants. So in this case, we decided to go for whole genome sequencing. And in the whole genome sequencing, we got an intronic variant here, a homozygous intronic variant in a known osteogenesis imperfecta gene. The prediction tools all predicted to be causing a donor gain. And therefore, we are yet to do a functional assay for this case, but we are confident that this is the causative variation for this family. So it's very important to discuss with the family what is the test being offered, what are the benefits, what are the alternatives of doing testing or not test at all, what results could be expected, what is VOS, what is an uninformative exome, etc. Then secondary findings, whether they want to know then they might, so that they're better prepared when the results come, limitations. Then there might be need for subsequent segregation testing in the family once the result of the program comes. So you need to tell all these points to the family so that they have a better understanding and are prepared for it. Then once you get the report, please critically analyze all the reports, irrespective of what the reporting lab has written in the lab. Independent analysis is always recommended, and you should always tell them about the possibility of changing or the dynamic nature of classification of variants, whether variants might change to a benign variant or pathogenic variant, depending on availability of new information. So just to end, we should always critically ask ourselves, is genomic test indicated in this particular situation? If so, then what test should be ordered? Once you decide to order an NGS-based testing, deep phenotyping is very, very important, preferably using standard nomenclature or the HPA terms, this should be accompanied by proper pre-test counseling. Once you get the report interpretation, you analyze the reports and by asking yourself, is this really the cause of the disorder in my patient? If so, you need to do post-test counseling accordingly. Reverse phenotyping is a very good learning point for almost all disorders, because these disorders are very, very rare. You get to see only some cases in your lifetime. So you will certainly miss many phenotypic features, but once you go back to the patient, it's always there. Then once you get an uninformative test result, what next to be done, limitations of the test, and you have to read. And reanalysis and reinterpretation is now an area of active research, and it is recommended now. There are consensus guidelines which say that reanalysis should be done at least every 6 months from once the report has been gone to the patient. So with this, I thank you very much for your patient hearing.